So, data from approximately the same cohort. Kidney transplant recipients carry a great burden of cardiovascular disease despite improved left ventricular remodeling after transplantation. Kidney allograft dysfunction and the immunosuppressed milieu play a major adverse role in myocardial structural changes in asymptomatic KTRs. There is an intricate relationship, on the other hand, between immune system responses with heart failure syndromes, including aberrant activity and counts of pro-inflammatory CD14 double positive, CD16 positive monocytes, natural killer cells, and T regulatory cells. Immune mechanisms in heart failure and cardiorenal syndrome are currently at the center of attention. The association of immune cells populations with subclinical markers of cardiovascular disease remain to be determined in kidney transplant recipients. So the aim of our study was to investigate potential correlations between blood levels of specific immune cell subsets with conventional and novel deformation-related indices of left ventricular function in KTRs. So far, we know that intermediate pro-inflammatory monocytes are independently associated with cardiovascular events in CKD, both non-end-stage and dialysis patients. These pro-inflammatory monocytes subpopulation decrease after kidney transplantation. However, even in kidney transplant recipients, they remain significantly associated with subclinical atherosclerosis as measured by carotid intima media thickness. With regard to acquired immunity, T cells from experimental models, recent experimental models, appear to play a causal role in diastolic dysfunction in uremic cardiomyopathy, and their depletion with monoclonal antibodies is associated with improvement in left ventricular function. So, 31 stable KTRs without established cardiovascular disease were enrolled in our study. We also included a control population of 17 patients with chronic kidney disease matched for AH and EGFR. Additional exclusion criteria were history of malignancy, autoimmune disease, and active or chronic infections. The peripheral blood immune cell subsets, both monocyte subtypes and acquired immune cell types and Tregs as well as NK cells were measured by flow cytometry, whereas by echocardiography, we and our team measured conventional, including left atrial volume index, left ventricular mass index, and E to E prime as a marker of congestion, as well as novel two-dimensional speckle tracking echographic indices of left ventricular function, including global longitudinal strain, global circumferential strain, global radial strain, twist, and untwist. Measurements were made simultaneously, flow cytometry and echocardiography. KTRs had a mean GFR of 58 milliliters per minute and mean 24-hour proteinuria of approximately 700 milligrams per 24 hours. Total lymphocytes, B cells, T cells, and CD8 positive T cells counts correlated positively with eGFR, whereas increased non-classical monocytes were associated with proteinuria, and there was an inverse correlation between the percentage of classical monocytes with proteinuria. Compared to their CKD counterparts, kidney transplant recipients displayed higher non-classical monocytes and higher classical, monocytes and lower non-classical monocytes, a lower percentage of NK cells and T cells, and lower Tregs compared to CKD patients after adjusting for confounders. With regard to correlation of immune cell subsets with classical and novel left ventricular dysfunction indices, we found that increased total monocytes were associated with an increased left atrial volume index, an increased percentage of the pro-inflammatory intermediate monocytes correlated positively with an increased E to E prime value. Both CD4 positive T cell number and Tregs were inversely correlated with E to E prime. Increased pro-inflammatory monocyte levels were directly associated with left ventricular twist and inversely associated with left ventricular twist. And finally, increased NK cells were associated with more negative GLS and GCS values. No significant correlations were observed between the rest immune cells with the classical or novel left ventricular dysfunction indices. In conclusion, alterations of immune cell subsets correlate with subclinical markers of left ventricular function in KTRs with no established cardiovascular disease, and future research is definitely required to evaluate the role of these subpopulations as tools to identify KTRs who are at the highest risk for complications and guide interventions. Thank you.